ഹലോ, എല്ലാവർക്കും നമസ്കാരം. എല്ലാവരും സുഖമായിട്ടിരിക്കുന്നെന്ന് വിശ്വസിക്കട്ടെ. ഞാൻ കഴിഞ്ഞ ദിവസം ഒരു കാര്യം പറയാൻ മറന്നുപോയായിരുന്നു. ഞാനുള്ളത് ഇപ്പോൾ യുകെയിലാണേ. ഞാനൊരു 20 ഇയേഴ്സായി ഇവിടെ വന്നിട്ട്. പിന്നെ ഞാൻ കഴിഞ്ഞ ദിവസം ഞാൻ പറഞ്ഞില്ലായിരുന്നോ ഒരു വീഡിയോ എടുത്ത കാര്യം, മാനേജിങ് ക്ലിനിക്കൽ റിസ്ക് ഇൻ റിമോട്ട് ട്രിയേജ്. അത് ഞാൻ പറഞ്ഞതുപോലെ ഒരു 1 മണിക്കൂർ ലെങ്തുള്ള വീഡിയോ ആണ്. കാണാൻ പറ്റുന്നവർ കാണുക. അത് ഇംഗ്ലീഷാണ്. മലയാളം വേണമെന്നുണ്ടെങ്കിൽ ഞാനത് ചെയ്യാം. അത് ആർക്കെങ്കിലും ആവശ്യമുണ്ടെന്നുണ്ടെങ്കിൽ ഒന്ന് മെസ്സേജ് ഇട്ടാൽ മതിയേ, ഒന്ന് കമൻറ്റിൽ പറഞ്ഞാൽ മതിയേ. ഇപ്പം 1 മണിക്കൂർ ലെങ്ത് ആയതുകൊണ്ട് കാണാൻ ഇത്തിരി ബുദ്ധിമുട്ടായിരിക്കും നമുക്ക്. പക്ഷേ പറ്റുന്നവരൊക്കെ കാണുക. അപ്പം പിന്നെ എൻ്റെ ഇഷ്ടമാണെന്നുണ്ടെങ്കിൽ കമൻറ്റ് ചെയ്യുക, ലൈക്ക് ചെയ്യുക, ഷെയർ ചെയ്യുക. പിന്നെ സബ്സ്ക്രൈബ് ചെയ്യാൻ പറ്റുന്നവർ അതും കൂടി ചെയ്യുക.
Many of you know that what is NHS 111 surveys. So I hope most of you are aware what does this do. But I will give a brief description. NHS 111 is a non-emergency and medical advice and triage service. So when I say non-emergency, we normally get calls with the urgent calls, but non-emergency means less urgent than 999. So I would say it's designed to help people to get the right care immediately, and it's available 24/7 and it's free to use. It provides advice for urgent conditions, and it's mostly what we do. We direct or signpost the patient to the most appropriate service like GP practice, walk-in centers, urgent care centers, or the emergency department. It's all depends on how urgent is the condition, and the calls are initially answered by the health advisors who are highly trained, as well as the clinicians. They will have to go through the some kind of like the assessment or the training and things. So they all are highly trained to assess the symptoms. So you can contact NHS 111 by phone, via online, and through the GP, your GP practice app. So you can get that anytime. So I would say that if it is like a life-threatening condition, so what is life-threatening? So it's like a cardiac condition, like a severe chest pain, or stroke symptoms, or any major stroke, major trauma, you should call 999 instead of 111. Okay, so now I'm going to move on to the session. What is clinical risk? Clinical risk is a possibility of harm to a patient care, decision, or actions, including mistakes, delays, or inappropriate management. This is why this happens. This happens because the assessment is carried out without a face-to-face examination. Okay, so now what is remote triage? So how many of you are doing remote triage? So please give me a thumbs up. Remote triage is the process of assessing patients' health needs without face-to-face consultation, usually over the phone, video call, or online messaging. Its aim is to rapidly and safely determine how urgent is the patient's condition and the most appropriate. So what are the most appropriate care pathway for that particular patient? So, and it is the aim is to minimize uncertainty and to make safe, timely decisions by gathering accurate information from the caller or a patient, often without visual cues or physical examinations. Okay, so now what are the clinical risks? What are the clinical risks in remote triage? As I mentioned earlier, the condition, the patients, if the patient is calling us regarding with the symptoms, the patient condition may be misjudged, delayed, or inadequately managed because the assessment is carried out without a face-to-face examination. So now, the clinical risk, how the risk can arise. The risk can arise because the assessment is remote. We can't see the patient. You can't see the patient or patient's body language, breathing. So you don't know how the patient is breathing. Breathing pattern, skin color. We don't know whether the patient is looking in great color or patient looks pale, or we don't know anything. So skin color or non-verbal cues. So you totally rely on the patient's description, which can be incomplete, unclear, or misleading. So which normally happens in remote triage. So there are other factors like communication barriers, accents, hearing loss, language differences, or caller or the patient may be quite anxious, so therefore they are unable to give us a proper symptoms. So sometimes we are having difficulty obtaining information from the patient if the caller is in distress or anxious. So the other important thing, I would say, the symptoms overlap. So that is quite, that's quite common, to be honest. So that means the mild symptoms may mask serious conditions, like if the patient is calling with a shortness of breath, the patient is in sepsis, but we don't know. So sometimes the patient will say, oh, I have a mild temperature and I don't feel very well. That's all. So they don't give us any other symptoms. So the symptoms may overlap. Then delayed escalation. If advice is given without recognizing the urgency, there may be a dangerous delay in treatment. So that means, so if we assess a patient, so we are failing to recognize the urgency, how urgent is patient condition. So that is delayed escalation. And caller perception, the next one. So patient might underplay or exaggerate their symptoms. So that is also common in remote triage. For example, if the caller if a caller describes just feeling a bit off with a temperature. So what do you think? So what do you think when you hear that? Okay, I'm feeling a bit off and I don't know what's happening. So I have a little bit mild temperature. So what you normally think? So you normally, when you hear that, in the first instinct, you don't think that like a sepsis. But in this, in this remote triage, so if you hear something like a breathing difficulty or temperature unwell, so you will have to think about the sepsis. So as a person, I do think about sepsis. Whatever case I deal with, I always think about sepsis because that can be easily missed. So in person, so when we assess the patient, so if the patient says that I'm feeling a bit off and temperature, so when we see as a person, in person, we can see if the patient is in breathing difficulty or they are confused. We can see them face to face, but remotely those cues can be missed. So if not probed correctly, you could underestimate the severity of the condition and delay emergency care. So here I would like to explain the probing. What is a probing? So in a simple word, probing is asking structured questions, but Structured means the clinicians, you can ask questions. So I think most people know that there is a pathway. There is a pathway to go for the clinicians or the health advisors. But for the clinicians, because they are clinicians, they don't have to go through that pathway like one by one. You can ask your own questions to find out what's going on. So the probing is just mean using targeted follow-up questions to gather specific, accurate information from the caller. So I would say under-probing. Under-probing is dangerous than over-probing. The under-probing, so if the patient give us a symptom and we don't, okay, so you have that, okay. If you would ask anything, so how that happened and how do you feel and how did that happen and when did this happen? So if you don't ask those questions, the decision or the urgency of the situation can be missed. So always I would say that under probing is dangerous than over probing. But however, over probing is also a problem because sometimes the patient may get very frustrated because we are asking lots of questions. Sometimes they don't think that we are trying to find out what's going on with them. So it's just do it just right. So that's what I would say. Okay, so in a probing, so if you want to clarify some symptoms like vague symptoms, if the caller says, I have got some chest pain or chest discomfort, so what do you ask? So what sort of questions do you ask in terms of determining what kind of chest pain is that? Okay, so we can ask, as a probing, we can ask, can you describe that? Can you describe that discomfort? How do you feel? If it is a pain, is it a sharp pain, dull ache, or burning? And does it spread anywhere, or when did it start? So there are more questions that you can ask, so then you will get a clear picture from the patient. And I would say key principles for effective probing in remote triage are: be systematic, be specific, and use open and closed questions appropriately. Sometimes when we say that open and closed questions, there are some questions that we can ask open and close. So that has to be asked appropriately with the speed and the depth. Okay, so which is important. Sometimes the patient would understand our medical terms. Therefore, sometimes we need to clarify. So we need to repeat. We need to clarify to make them understand. So what are those what we are asking that. So what are the key features of clinical risk in remote triage? Reliance on patient or caller symptom description. So as I told you earlier, so we don't know we can't see the patients, therefore we rely on their symptom description. So limited non-verbal cues like pale, as I told you earlier, if the patient pale or pallor, how is their breathing pattern? No physical examination. We are not doing physical examination, or there is no immediate investigations. If the patient is in hospital, they can go for the investigation and they will do the investigation. But remote, we can't do the investigation or anything. And the other thing is communication barriers, language. There are people with different languages, and if the patient is in distress, and background noise, this all make remote triage a little bit risky. And sometimes a caller minimizing or exaggerating the symptoms, and high workload and time pressures. Of course, we have workloads and time pressures. So it's all about assess patient safely, okay, and manage your time as well. And there are a few types of clinical risk. The first one, missed serious conditions like sepsis, acute coronary symptoms, or meningitis. Okay, so here I would like to give you an example. I have assessed a patient recently. A patient, the symptom was indigestion. So patient is saying that she's feeling some indigestion. She has taken Gaviscon. Then when I had the indigestion, I asked her whether she has any chest pain or she had any chest pain in the previous 24 hours. And she said, no, I didn't have any chest pain. I have no chest pain at all. Then when I asked the palpitation, whether she had any palpitation, she denies the palpitation, and she denies any nausea, vomiting, nothing like that. So what triggered me was the urgency in her voice. So she said that she never ever had such experience, and she doesn't know what's happening. She said she had some indigestion, and which relieved with the Gaviscon. So, but during the assessment, she kept saying that I don't have any chest pain. But at the end of the call, so after the assessment, I didn't feel that it's that urgent. So what I asked, the last question I asked her was, how do you feel now? And she said that she has a weird feeling in her chest. No chest pain, but weird feeling in her chest. And she's in that urgency. She says she never ever had the symptoms. So what I did was, instead of sending her to the doctor for a non-urgent appointment, I sent her to the A&E department. So she went to the A&E department, which I confirmed that she went to the A&E department. So here, so we can miss symptoms, so if we haven't assessed the patient properly. So the next one is the delayed escalation to urgent or emergency care. Again, if we are not assessing the patient correctly, we can delay the escalation to urgent or emergency care. And inappropriate self-care advice leading to deterioration. So here, sometimes patient can underplay their symptoms. And so if we are unable to find out any urgency in their condition, then it is leading to deterioration if there is any severe symptoms. And the next one is failure to provide effective safety netting. The safety netting is very, very important in remote triage. What is safety netting? Safety netting means there are few things that we need to tell the patient at the end of the call. So like, if any worsening symptoms in their condition, or if they develop any new symptoms, or if they have any concerns, they can call us back. There is no time limit. They can call us back anytime. And also there are some watch for. So according to their symptoms, what you need to watch for. So you need to watch this and that. So if you have this one, you will have to contact the 999, or if you have this one, you will have to go to the A&E department. Even if you develop this and that, then you will have to contact us. So there are watch force and the safety netting, which is very, very, very important, because the patient doesn't know. Sometimes the patient doesn't know what to do if their condition deteriorates or if they develop any new symptoms. So therefore the worsening is very important. And the last one is over escalation causing system strain. So what is over escalation? Over escalation, if you have assessed a patient and you are sure that, okay, patient does not need to go to the urgent care, or no hospital, no GP, nothing, the patient's symptoms can be managed safely at home. So you know that you can give that. So you can give the advice what they need to look for, again the safety netting and things. But sometimes you do like just in case. So what is just in case? There is no just in case in 111 service. There is a clear cut worsening symptoms. So you can't say that, if you feel, or if just in case you call us. No, there is no just in case in 111 service. Okay, so what are the common risk scenarios, like a typical high risk cases? Okay, the typical high risk cases are like children with vague symptoms, like irritability, fever, poor feeding. And the next one, elderly callers with non-specific complaints, like false confusion. So they had a fall and they are confused. They don't know the reason for those. So when we hear the false and confusion, we have to think about what are the risks associated with those symptoms. Then we have to dig in. So what could be this, what could happen, and things like that. So we need to dig into that, the symptoms. And the other one is mental health concerns or suicidal ideation. Mental health concern is, it's a really difficult situation. So sometimes it's even sometimes we struggle to handle the mental health cases, and sometimes the patient call us without telling us their name, their location, and no details, where we struggle to gather the information, and it delays sending the appropriate care for the patients. So then we will have to liaise with the resources outside. Then then we will have to manage the patient with the help of the outside resources. Okay, chest pain or breathing difficulty. This is also high risk. Chest pain can happen due to different reasons, and the breathing difficulty as well due to different reasons. So we have to differentiate, or we have to think, so what it could be, or what is that. And so potential, and the last one is the potential sepsis presentation. If the patient sometimes they do have like one symptoms, like mild breathing difficulty, there's no other symptoms. So that is one risk. So often the sepsis can be missed easily. So therefore the sepsis symptoms that so we need to assess the patient thoroughly and safely. Communication challenges, that is other risk, as I previously discussed. Language barriers, hearing impairment, cognitive impairment. So the language barriers, so we have language line in place. If the patient calls us, a patient with a different language, or a patient is unable to speak English, we have the resource in place that we can contact language line to assess the patient safely. And the other risk is that emotional or distressed callers. Emotional, sometimes the patient, call us with, they are emotionally very, very disturbed, and we will have to, so we can't jump into the symptoms. So okay, so why did you call us then? Give me the details. So that we can't do that. So just if they are emotionally distressed, give them peace and time to calm down. Once they calm down, definitely they would. They soft voice, and if we give them the peace and the time, they will calm down. I have lots of experience, and at the end they will speak to us clearly. Okay, so now the important thing is how we can risk manage. How can we manage those risks in remote triage, which is important. Structured history taking is very important. So if I say, what is structured history taking? So structured history taking is the history of the patient. Okay, so if the patient has any allergies, if they has any medical condition, past medical condition, if they are taking any medications, and the fluid intake, the food and fluid intake. So when did they have something to eat, and so how they feel, and those things, these are the structured history taking. So I always go with amble, which is allergies, medication, and things like that. So it is very, very helpful tool. So I would recommend, if there are any nurses who are doing the remote triage, go by amble. Use S-bar, which is a situation, background, assessment, and recommendation. So S-bar, okay, so we need to assess the situation and background. Sometimes, suppose if the patient is a child, so child is like child means suppose they are 1, 2, 3, 4. So always when we speak to parents, we have to listen any background noise, if the patient is talking, or if there is no noise, or any breathing, any grunting noise of breathing, or how they are breathing. So we need to always, while talking to parents, we always, back of our mind, we have to be very careful. Okay, and so here I would say that always speak to the patient. So we can speak to the patient directly. So what happens when we speak to the patient, we can assess their breathing. So how they are, so if they are breathless, they will be unable to complete a full sentence. If they are able to complete full sentence, that means the patient is not breathless. So you can say that, okay, the patient is breathing. There is some mild disturbance, but patient is not struggling to breathe. So, and you can assess their consciousness level. How conscious are they? Are they able to talk to you appropriately, or are they able to give you answer properly? So, and so you can also recognize if they are confused or anything. So this all make the assessment easier. So we have a protocol that we have to speak to the patient. Sometimes we do get like remote callers. The parents, if the child is in school, the parents are calling us regarding the symptoms. But in that case, we won't be able to assess the patient, because we will have to speak to the patient. So if the child is under 4 years, of course we would speak to the parents. So if they are above 4 years, we always try to speak to the patient. In any case, if they are unable to speak in any case, then we will ask the parents that how is their breathing? Are they breathing normally? If they are able to stay awake for a few seconds, if they are conscious and alert, those things. So when we speak to the patient, we can forget about all those things. So as I said, the remote caller. So we are unable to complete the assessment with the remote caller. So if the caller is with the patient, even though if we are unable to speak to the patient directly, then we can, but the caller has to be with the patient, with the in the same room, so we can, they can see how the patient is breathing. But if instead if the caller is somewhere else and the patient is somewhere else, then we won't be able to assess the patient safely. Sometimes the callers get frustrated because we are not letting them to speak. They say that, I know, I was with the patient 30 minutes ago, so I know how they are, I know their symptoms, but unfortunately we are unable to, because if we do that, we are risking the patient and as well as the system. So always better to speak to the patient. And active listening is very important. So when we speak to the patient, give full attention to the patient. So because you can't see the patient and patient can't see you, so use verbal notes and do not repeat questions, so that will make them frustrated. So if you are struggling to understand, what you can do, what you can write down, and you can confirm that with the patient. Okay, so you have, you told me this and that, is that correct? So they feel like they have been listened to. So avoid repetition, but you can confirm. And the next one is use structured triage protocols. So NHS 111 has pathways in place. There are pathways for each and every symptoms that patient appear with, but you will have to decide which pathway is the most appropriate for the patient according to their symptoms. Okay, so the next one is apply clinical judgment to override disposition. Okay, so what is disposition? Disposition is you assess the patient, and so at the end of the assessment you will find an outcome. The outcome totally depend on your assessment, the way you assess the patient, how you assess the patient. So when you get that disposition, you need to think about, okay, is this appropriate for the patient? Is this right for the patient? So if you in any case, if you think that, okay, I am not happy. So suppose the patient has been having the symptoms for a long time, like 1 month, 2 months, and the outcome after the assessment you got was send the patient to the A&E department. So I would say that if the symptoms has been going on for 2 months, there is no worsening, then you will have to think about that disposition, whether this is appropriate for the patient, whether this is appropriate for the system, or whether this is appropriate for the service we are going to send the patient. So in that case, we can change that disposition, and so you can write down why you have changed that disposition. So give the reasoning. So why did you do that? So you can justify why you have done that, why you think patient does not need to go to the hospital, and why you think that so this is appropriate for the patient. And the next one is the targeted probing. So I already told you about the probing earlier. What is the importance of probing in remote triage? So ask targeted questions or closed questions to find red flag symptoms. So as previously discussed, red flag can be easily missed. If the patient call us regarding, they are feeling tired, it's no symptoms at all, just tiredness, extreme tiredness. So then you will have to think about why the patient is tired. So how long this has been going on? Is the patient is able to do any of their normal activities? If they are able to make a cup of tea for yourself, if they are able to watch TV, even though if they watch TV, are they just staring at the screen, or they are actively watching? So all these things you need to. So there are so many questions to ask to conclude the urgency or what's going on with the patient. So don't afraid of asking questions. So if you think that is appropriate, ask the questions. So at the end of the day, it is for the safety of the patient. So then the next one is the give clear jargon-free advice. What is jargon-free advice? Okay, so that means we have some medical terms, isn't it? So like special words, so which are not understood by the patient. So give them simple wording which can be, which they can understand. And at the end, you can ask the patient whether they understood that properly. So if they are unable to remember the instructions, so some cases if we give the home advice, then there are lots of things to remember. Sometimes they are unable to remember. So always ask them to write it. Get a pen and paper to write down. So write down so what they look for, what they watch for, when do they need to call us, things like that. So I always do ask my patients to write down if they are struggling to remember. So provide robust safety netting advice, so including watch for, when to call back, and what to look for. And document exact caller wording, like advice given and reasoning. So the other thing, so I find a little bit difficult in the beginning that so while we are talking to the patient, we have to type it. So it was a little bit difficult in the beginning, but with the experience you will get used to it, and so it won't be a problem thereafter. So I hope you guys understood that what are the risk management strategies. So now there are escalation pathways. Suppose there are immediate referral that we can make. We can send emails to the hospital, to the acute medical unit, A&E department, or the urgent eye condition. We can send the patients to their same day appointment. We can make referral, and they can see the patient if that is appropriate for the patient. And you can contact, so if you are planning to send the patient to an urgent treatment center, so you can always contact them. So if you are in doubt, you can ask them, okay, I would like to refer this patient to your service. So are you able to accept this patient? So if they are able to accept, they will tell you, yes, send the patient and send the referral. So if they are unable to patient, suppose the urgent treatment center, if we send the patient with acute coronary syndrome, they won't be able to see the patient, because that is out of their depth. So that would need emergency admission. So always we can ask. We have like clinical advice line. So if the health advisors or the nurses are stuck with anything, we can always contact the clinical advice line, and we have clinical point of contact. We can contact them. If they are unable to help, there is like a clinical bridge. We can contact them. They will give you clear-cut advice. So what you need to do. So there is no place for panicking. So there is always help available. Okay, so now what I'm going to do, I'm going to give you a few scenarios like how we can manage those clinical risks. Okay, scenario 1, fever. The patient is fever and weakness in an elderly patient. A 68-year-old man calling, feeling generally unwell with mild fever. So what do you think? So when you receive that call, what do you think about what risk associated with those symptoms? And also patient confirm some fatigue but denies chest pain, shortness of breath or other symptoms when asked broadly. So here you need to think about what questions, what probing you need to ask the patient. So under probing could lead to missing sepsis or early pneumonia. If the elderly patient calling me with these symptoms, I would ask, how, if the fever is fluctuating or any confusion or any dizziness or any rapid heartbeat, or are you having difficulty when walking across the room, that sort of things. Then if the patient says that then the patient says that I have had these symptoms this morning, and that sort of things. So then you can conclude what is going on. And the other thing that I would ask, food and fluid intake and urine output. The patient with sepsis, there will be reduced urine output, which is important. So you need to ask how much they had, how much fluid they had, and how much urine they have passed. It's everything all together, we can come into a conclusion. But we are nurses, we are unable to diagnose. But if we have any doubt, we can always write, okay, I am concerned. If you are referring a patient to somewhere, you can always write, okay, so I am concerned with this patient with these and these symptoms or red flag symptoms. So when the patient go to the hospital, they will read our notes, they will assess the patient accordingly. So the outcome with effective probing will be, the caller then mentions he felt disoriented this morning and has a slight shortness of breath on exertion. If we don't ask them any confusion or any breathing, they won't tell us. So therefore important. So always think about importance of probing. So these are the red flags, like the confusion and the breathing issues. Okay, so the next one, the scenario 2 is the abdominal pain in a young adult. 25-year-old woman calling with stomach pain for 2 days. So when we hear stomach pain, what would you think? So what risk is associated with the stomach pain? It could be appendicitis, it could be, if it is lower abdominal pain, it could be urine infection, it could be an ectopic pregnancy, it could be anything. So the probing question should be, so what would you ask? The question should be asking pain, location, migration and severity of the pain. You can ask associated symptoms like vomiting, diarrhea, or because the patient is a 25-year-old woman, ask about last menstrual period and pregnancy risk. It could be ectopic pregnancy. So always ask, we have to explore each and everything. And the outcome is pain in lower right quadrant with nausea. So refer the patient to urgent face-to-face assessment. Okay, the scenario 3, shortness of breath in a middle-aged patient. 50-year-old man calling us, just a bit breathless today. So when you hear the breathless, what would you think? So what are the risks associated with the breathing, breathlessness? It could be ACS, acute coronary syndrome, or acute heart failure, or pulmonary embolism. Then the probing question should be onset and severity of the breathlessness. Any chest pain, or any swelling, or any past medical history of any heart disease or blood clots. Okay, so after all those questions, what you will get, the outcome will be severe exertional breathlessness and leg swelling. So which is an urgent or emergency condition that should be escalated to the urgent care. Okay, so always think about, believe your instincts, do not miss anything. So if we hear a symptoms associate together, so you have to make like all the questions. Okay, so what all questions I should ask? Okay, so do that way, do systematically. So pediatric, the next scenario is a pediatric high fever. Mother is calling us, mother of a 3-year-old child. Mommy is saying that my child has a temperature of 39 degrees Celsius. So what risk we would think if mom calls us with the fever in child? So it could be infection, any infection, it could be a normal fever, it could be meningitis. Okay, so here I would like to give you an example. Okay, so as you people know that 111 can use video calls to see the patient. So recently, I had a call from a mom. The child is 18 months old. A child had the fever for the past 2 days. Eating and drinking is not too bad, but child is a little bit irritable. Mom says that there is no breathing difficulty, but the high fever, despite giving the medications. So when I asked the mom that, has the child developed any rashes? Mom said, no, there is no rashes. So what I did was, I asked her, when did you check the rashes? Mom told me half an hour ago. I said, okay, no worries, just to check the rashes now, whether the child had developed rashes. Mom is insisting that, no, there was no rashes. I said, absolutely fine, just to have a look, please. Then at the same time, I made a video call. Then mom, all of a sudden, mom told me that, yes, she had developed some rashes on her leg. So when I had a look, I doubt it. I sent the patient straight away to the A&E department. See, so sometimes we have to repeatedly ask the parents to do things. So sometimes they are frustrated. They are thinking that why they are asking me. Though I have already checked that it wasn't there. So what's the point checking me now? But there is point. So that's why. Okay, if you ask, do not ignore. Okay, so you checked earlier, so okay, that's why no. So that right moment that you have to see how is the patient. Okay, so the previous scenario, the child has a temperature of 39. So has child developed any rashes, lethargy, or any seizure, any changes in behavior, any vomiting, or any recent vaccination? So the child appears, after the assessment, child appears lethargic with a rash, immediate escalation to the emergency. Okay, the last scenario, chest discomfort in a smoker. 60-year-old man with a mild chest discomfort on and off. Okay, the risk associated with chest discomfort, cardiac ischemia or myocardial infarction. So we need to think about all, everything. It could be a symbol like a muscular pain, but we can't miss anything. So what you need to ask with the discomfort or the pain, nature of the pain, is it a sharp pain, or it's a dull ache, or it's a crushing pain? and any radiation to arm, any pain radiating to neck or jaw. And you can always ask nausea and vomiting. Have you had any nausea or have you been vomiting with the pain? If any of those yes, then we need to think about, so what is it? So and also the history, like risk factors, like any cardiac history. If the patient call you with the chest pain or chest discomfort, I normally ask the question. The first question would be, do you have any heart condition, or are you taking any medications? And then the severity of the pain and things. And so after the assessment, the outcome will be pain worsens with exertion and radiates to jaw. So the acute ambulance, emergency ambulance, high priority, acute coronary syndrome. So this is what we have to, the probing is very important. Okay, the learning points across all scenarios. Always use structured probing to uncover hidden severity. If we ask structured questions, then it will be a safe assessment. So we need to think what we should ask. There is no questions like I told you that there is a pathway, NHS pathway, but there is no questions like, okay, so you need to ask the patient this and that. No. So there are something like a brief, but although these questions we have to think, so we have to ask them. Okay, and there is nothing like written questions that you have to ask them this and that. No. So we have to. So we are clinicians. So we know when we hear something, we know what's happening. So we have to think what questions we should ask. And recognize red flags early. Escalate appropriately and document thoroughly. And use safety netting device when risk is uncertain. Okay, so therefore, safety netting, worsening advice, including watch for, is very, very, very important. Okay, so now, ethical and legal consideration. Nurses must operate within their scope of practice. As I told you earlier, so we cannot diagnose. So we can always write down, I am concerned. There is no diagnosis, such a diagnosis. We are unable to make any diagnosis. So therefore, we have to operate within our scope of practice and always make sure, maintain confidentiality and document thoroughly. Understand duty of care and consent is critical. So there are like safeguarding issues as well. We have to take consent from the caller or the patient. And to conclude this, risk is part of clinical care, but we have to manage it actively, safely, be thorough, curious and cautious. Communicate effectively and escalate early. Everything should be fine. So think about what we should ask. Okay, so if we hear something, think about, okay, what this could be. So what, how this can be managed. Can this be managed at home, or does the patient need something else? Okay, so think about it twice. And remote triage demands vigilance, communication and clinical insight. So that's end of our session, and I hope you all enjoyed the session, and I hope you have gained some knowledge from the session. And once again, thank you for joining me today. Thank you so much, and have a good evening to all.